Welcome to A4 Medicine. This is the Breathable Pathway, a practical guide to the latest NICE, BTS, and SIGN asthma guidance for adults and young people aged 12 and over. The big message is this is not just a small tweak to the old asthma ladder. The whole treatment model has shifted toward one key principle. Whenever a patient takes a reliever, they should also be getting inhaled steroid. That is the logic behind the entire pathway. In primary care, most asthma is managed by us. That means prescribing habits, review habits, and inhaler habits in everyday clinic are what really change outcomes. For years, many patients learn to think asthma mainly as a bronchospasm problem. Tight chest, wheeze, use the blue inhaler. But the updated guidance is trying to correct that mental model. Asthma is fundamentally an inflammatory airway disease. And if we only treat bronchoconstriction, we can make symptoms feel better without reducing the real risk of future attacks. The headline change is simple. Short acting beta agonist or SABA only treatment is no longer recommended as routine care for most people aged 12 and over. Instead, the new default is low dose ICS steroid formoterol, either as AIR, meaning anti-inflammatory reliever therapy, or MART, where the same inhaler is used for both maintenance and relief. Why? Because every time the patient gets dilation, they also get anti-inflammatory treatment that is safer, more logical, and better aligned with how asthma actually behaves. One of the most practical parts of the new pathway is the definition of uncontrolled asthma. You only need one of the three markers: a recent exacerbation needing oral steroids, reliever use on 3 or more days a week, or night waking once a week or more. That matters. This is a risk based definition, not a perfection based one. If any of those is present, that patient is telling you their asthma is unstable, and that should trigger a proper review. Before escalating, this slide may be the most important in the whole deck. Before you escalate treatment, fix the basics first. Check adherence, check inhaler technique, ideally by watching them use it. Reconsider the diagnosis. Look for comorbidities such as rhinitis, reflux, obesity, or sleep apnea. Ask about smoking, vaping, mold, seasonal triggers, and psychosocial barriers. Because most uncontrolled asthma in primary care is not a true drug failure problem. It is often a technique problem, an adherence problem, or an exposure problem, or even the wrong diagnosis. The whole pathway becomes easier once you understand just two concepts. AIR or AIR means a low dose ICS formoterol, inhaler taken only when needed. So when symptoms appear, the patient gets quick relief and steroid at the same time. MART means the same inhaler is used both regularly and as needed. One inhaler, two jobs. That is powerful because it aligns with what the patient feels helps immediately with what actually prevents future attacks. For newly diagnosed asthma in people aged 12 and over, the recommended starting point is as needed low dose ICS formoterol, in other words, air therapy. That is a major conceptual change. We are no longer starting with the blue inhaler alone and adding steroid later. We are starting with a reliever that also treats inflammation from the beginning. The exception is the patient who is highly symptomatic at presentation or has severe exacerbations. In that situation, the safer option is to go straight to low dose MART because they need regular anti inflammatory cover, not just symptom triggered treatment. If air is not enough, the next step is low dose MART. This is the point where we move from as needed only treatment into a regular maintenance plus symptom relief, but still using the same ICS formoterol inhaler. For busy primary care, that simplicity matters. It reduces confusion, reduces inhaler mix-ups, and means that when the patient starts deteriorating, they automatically increase their steroid exposure as well as their bronchodilation. And importantly, if control is achieved, the guideline also says to consider stepping down. Stepping down is not failure, it is good prescribing. If asthma remains uncontrolled on low dose MART, the next step is moderate dose MART. But this is the point where the guidance becomes more selective. Moderate dose MART is really the top of the ladder that sits comfortably in routine general practice. If the patient is still uncontrolled here, despite good technique, good adherence, the answer is usually not to keep climbing the ladder. At this point, the real question becomes, what type of asthma is this? This is where the pathway becomes smarter than the old staircase model. If someone is uncontrolled on moderate dose MART, despite good adherence, the key question is this type 2 inflammatory asthma? And NICE makes the triage quite simple. Check FeNO, which is fractional exhaled nitric oxide, if available. Check the blood eosinophil count. Those two biomarkers create the fork in the pathway. They tell you whether the patient is likely to need specialist phenotype driven care or whether a structured primary care add on trial is still appropriate. The point of this fork is to stop us treating all uncontrolled asthma as if they were the same disease. If either biomarker is raised, that suggests ongoing type 2 inflammation. And those are the patients more likely to need specialist assessment and potentially biologic directed thinking. If both are normal, type 2 inflammation is less likely, and there may still be room for a more conventional add on approach in primary care. So, this part of the guideline is really moving us from blind escalation to phenotype aware prescribing. If either FNO or eosinophil is raised, the recommendation is to refer to a specialist in asthma care. The practical message is, do not keep piling on inhalers when the biomarkers are telling you that the patient may need a different level of care. These patients may need full phenotyping, advanced risk assessment, and treatments that sit outside the routine general practice. So, raised biomarkers are really a signal to stop stacking and start referring. If both the biomarkers are not raised, NICE recommends a structured trial of either a LTRA, which is a leukotriene receptor antagonist, or LAMA on top of moderate dose MART for 8 to 12 weeks. That is sensible primary care move. It lets you test lower risk add on options that might address other mechanisms of disease without over medicalizing or prematurely referring everyone. But the key is that this must be a time limited reviewed trial, not a treatment that quietly stays on repeat forever. The strength of the new pathway is that it tells you how to review properly. If asthma is now controlled, continue the treatment. If it has improved but is still inadequate, continue it and try the alternative add-on as well. If there is no improvement, stop it and switch. And if asthma remains uncontrolled after those structured trials, refer. That is much better than indefinite medication accumulation. One practical point here, if you use Montelukast, remember the MHRA advice about possible neuropsychiatric side effects and warn the patient. This is one of the most useful slides for day to day primary care. Most of our asthma patients are not newly diagnosed, they're already on legacy regimens. So the pathway helps us map older treatments into the new AIR MART model. A patient on SABA alone should not just get another repeat prescription. They should move on to AIR or to low dose MART if symptoms are more marked. Someone uncontrolled on low dose ICS based treatment becomes a candidate for low dose MART. Someone uncontrolled on moderate dose combinations becomes a candidate for moderate dose MART. And if they are already uncontrolled on high dose ICS, that is usually a referral point, not a cue to keep escalating in primary care. If you stand back, the whole pathway is actually very elegant. Start with ICS formoterol as needed, escalate to low dose MART, then to moderate dose MART if needed. Pause and fix the basics before every escalation. Once moderate dose MART fails, let the biomarkers decide whether this stays in primary care or moves to a specialist care. So this is no longer a long staircase of even ever more inhalers. It is a shorter, smarter pathway built around inflammation, simplicity, and phenotype. If I had to reduce the whole update to 5 messages, they would be these. First, SABA-only treatment is no longer the routine strategy. Second, whenever possible, reliever use should bring inhaled steroid with it. Third, anyone, any one marker of poor control is enough to trigger action. Fourth, fix the basics before escalating. And fifth, if moderate dose MART fails, stop guessing. Phenotype the patient. That is the sense of the breathable pathway, and that is what makes the guidance genuinely practical for primary care. So the key message is simple. Do not separate bronchodilation from anti-inflammatory treatment. Do not let frequent blue inhaler use reassure you. And do not keep escalating inhalers when the biology is asking a different question. That is the logic behind the latest NICE asthma guidance, and that is A4 medicine breathable pathway. I hope you like this video, and I hope you've watched our previous videos. I'll appreciate if you could please subscribe to our channel. Visit our website a4medicine.co.uk, where you will find useful books and education materials, including MCQs and AKT questions. Thank you.